Hi, everyone. We're really excited to have everyone back for another medicine grand rounds. So today we'll be talking about nephrotic syndrome and proteinuria. So joining us, we have Dr. Sayna Norouzi from Loma Linda University Health. Dr. Norouzi completed her medical degree at Tehran University of Medical Science School of Medicine. She finished her internal medicine residency at St. Louis University School of Medicine and then went on to pursue a fellowship in nephrology from Baylor College of Medicine. She is American board certified in internal medicine and nephrology. She practices complex cases involving the kidney and uses her expertise to provide patients with the most comfortable and satisfactory care. So we're very, very happy to have her here today and very excited to learn about proteinuria and nephrotic syndrome from her. So if you have any questions, feel free to throw them in the chat. We'll also have time for questions later. And with that, Dr. Norouzi, I hand it over to you. Thank you.
Well, thank you very much for the kind introduction, and hi, everybody. I'm really happy to be here. Thank you for having me here. It's such a privilege and such an honor to, to have this lecture today with you guys, and thank you for joining us. This topic is really close to my heart, and I'm a director of our glomerular disease clinic here, and I deal with proteinuria and nephrotic syndrome all the time. I think understanding proteinuria, how edema happens, and nephrotic syndrome, it's really important because at some point, if you have a patient with proteinuria and or nephrotic syndrome, and if you have a good understanding of this topic, you're going to be able to help them in a different way, and you're going to be able to change their lives. So with that, I'm going to start. So let me start with this. I'm a kidney doctor, and a lot of patients that I see, they have elevated creatinine and they have acute kidney injury. And as we know, AKI has different reasons. We focus on pre-renal, post-renal, and intrinsic disease. As we know, glomerular diseases, when we have proteinuria or nephrotic syndrome, it can cause intrinsic disease and it can cause AKI as well. It's not like every time that we have proteinuria, we're going to see a rise creatinine or a low urine output, but it can be one of the reasons. So this algorithm doesn't mean that each time that you have a patient with lupus nephritis or diabetic nephropathy, your creatinine is going to be elevated or you're going to deal with AKI, but it can happen. It's one of the reasons. Let's start with proteinuria. I'm going to start with a case scenario. As I said, I sit in my GN clinic multiple times a month. And for example, this is one of my typical patients that comes to the clinic. So you are at the nephrology, at the glomerular disease clinic with a nephrology attending. She asks you to evaluate a 45-year-old female with history of diabetes, diabetic nephropathy, and now with severe swelling on her legs. On her urine analysis results, she has proteinuria about 5 grams per day in her urine, and you get a detailed history and present the patient. But how do you define proteinuria in this patient? Does she have nephrotic syndrome? This is what your attending asks you. Let's go over this table. So there is a difference between nephrotic and nephritic syndrome. When we are talking about nephrotic syndrome, we're usually talking about proteinuria more than 3.5 grams per day. On the urine cast, you might see fatty casts. You might have hematuria or not. Hematuria is not a requirement for nephrotic syndrome. And when you're looking at your patient and you're examining your patient, you're going to see generalized edema. You're going to see some edema around their eyes, and they might have hypertension. Comparing that to the nephritic syndrome, in nephritic syndrome, you usually have hematuria. So the difference between these two is that in nephrotic syndrome, you might see hematuria, but in nephritic syndrome, you should see hematuria. The proteinuria should be less than 3.5 grams per day, and you're going to see some RBC casts in the urine. These patients, they usually have hypertension, but the amount of edema and the swelling that you're going to see on your patient is not as bad as nephrotic syndrome. So our patient had 5 grams protein per day in her urine. Can you tell me if she has nephrotic proteinuria? Well, yes, because we just showed the table that if you have more than 3.5 grams of proteinuria per day, you're going to have nephrotic range proteinuria. So you're correct. She has nephrotic range proteinuria. Now let's see if our patient has mild, moderate, or severe proteinuria. Why is it important? Is that, for example, I have a lot of residents and medical students come to my GN clinic, and they usually try to present the patient in a really good way. They tell me about all the details. But as someone who's going to decide about their therapy plan, I really want to use these words in my mind so I can categorize my patient. I want to know that if my patient has mild, moderate, or severe proteinuria. So I usually ask my residents, when our patient has 5 grams per day of proteinuria, how do you define this patient? We know that patient has nephrotic range proteinuria, but is this proteinuria mild or severe? This is a table from our guidelines. And as you see, if your albuminuria, if your proteinuria is less than 30 milligram per gram, it's going to be kind of mild proteinuria. If it's more than 300, then you can call it severe proteinuria. I know these are the names, and you might say that it doesn't matter, like if I know that it's mild or moderate. But then when you go back to the guidelines and clinical trials to make decisions for your patients, you need to be able to categorize your patients into different groups. We talked about nephrotic syndrome and the difference between nephrotic syndrome and nephritic syndrome. But when we talk about a syndrome, whenever you say syndrome, it's a combination of symptoms or a combination of findings whenever you use syndrome in medicine. So nephrotic range proteinuria by itself does not equal to nephrotic syndrome. What is the nephrotic syndrome criteria? You should have proteinuria more than 3.5, as we talked before, so nephrotic range proteinuria. But as a result of nephrotic range proteinuria, your serum albumin is going to be less than 2.5. You should see edema in your patients, and you're going to see hyperlipidemia and issues with the coagulation system as well. So in order to call a patient, to tell to a patient, or just writing it down on their chart that they have nephrotic syndrome, they have to fill out this criteria. You cannot use nephrotic syndrome term for patients that only have proteinuria more than 3.5. So you look at their serum albumin, look at their physical exam, make sure that they have edema, look at their lipid panel, and if they have hyperlipidemia and coagulation issues as well, at that point, this is a nephrotic syndrome patient. I found this online from the Curbsiders, and I really love their group. I think they're doing amazing work in podcasts and everything. And this is a visual abstract. And as you see, they are showing a range of nephrotic and nephritic disease in patients. So as we talked, in nephrotic range proteinuria, we see more proteinuria. Like in a nephrotic disease, nephrotic syndrome, we're going to see more proteinuria. And in the nephritic syndrome, we're going to see more kind of hematuria. So the hematuria is going to be hallmark of nephritic, and for the nephrotic, is going to be the proteinuria is going to be the hallmark of the disease. And based on that, we can remember what kind of diseases in the GN area is going to be nephrotic syndrome, and they can cause nephrotic syndrome. So we all know that minimal change disease is usually a patient who comes in with edema and a lot of proteinuria. So this patient, this minimal change disease is going to be under the nephrotic syndrome category. FSGS, the hallmark of FSGS is usually a lot of proteinuria as well. And then you have diabetic nephropathy as the leading cause of the kidney disease in the United States, that you can see it on the nephrotic range proteinuria and nephrotic disease, because you usually see a lot of proteinuria with patients who have diabetes for a long time. And if you want to compare it to the nephritic syndrome, you usually see vasculitis in the nephritic syndrome category, because the hallmark of vasculitis, if you think, is usually hematuria. And as we said, that hematuria is more prominent in nephritic syndrome patients. And then you have some patients that they might be as part of the nephrotic syndrome or nephritic syndrome. So they can show different pictures and different kind of, these patients actually You can say that they can be in different groups anytime, depends on the stage of their disease. And one of them is lupus nephritis. Lupus nephritis is one of the main patients that you might see at the GN clinic, and they can come in different shapes and different kind of presentations. Sometimes hematuria is the main kind of typical presentation for them, and sometimes nephrotic range proteinuria is the main presentation for them. So, or IgA could be in different ways as well, but you usually see IgA in the nephritic syndrome category. So I love this visual abstract because it's summarizing everything for nephrotic syndrome and nephritic syndrome here. Again, focusing on nephrotic syndrome, as we said, proteinuria, and then you're going to have low albumin, edema, hyperlipidemia, and coagulation issue. And I want you to remember this criteria for the nephrotic syndrome and make sure that you, when you use the term, you know the criteria before labeling a patient with a syndrome. And we usually, after we see that patient has nephrotic syndrome, we order specific labs because we are looking, for example, for membranous nephropathy, lupus nephritis. So these are the labs that we order for that. But we all know that most of these patients are going to need biopsy as well, unless you're dealing with membranous nephropathy, that we have new markers, for example, anti-PLA2R, that can help you to diagnose the patient without a biopsy. But even in membranous nephropathy, the role of biopsy is indispensable because you need to know how much fibrotic tissue you're dealing with before starting a therapy for your patient. Imagine you telling a patient that you need Cytoxan or rituximab, kind of a chemotherapy regimen for the next 6 months or for the next year. And you need to have a good understanding of the kind of how much fibrotic tissue you're dealing with, because you want to know that if the patient is going to respond to the therapy. Your patient is going to have a lot of side effects because of these infusions, and they want to know that if there is any point in trying these medications, and biopsy is going to guide you to give you more information and to give your patient a chance as well. Because sometimes if you see, like, for example, here in the area, sometimes patient comes to my clinic and they say that I was told that I don't need like the treatment anymore because my creatinine is up, and my doctor told me that you probably have a lot of fibrotic tissue. And without a biopsy, you can't say it for sure. I can't say for how many times after biopsy, even though that the creatinine is on the higher side, it's just an AKI and patient doesn't have a lot of fibrotic tissue, and you can treat them and you can give them a chance to not to go on dialysis. So biopsy is a gold standard for these patients, especially if you see multiple syndromes, like multiple symptoms, like if the patient is filling out the criteria for nephrotic syndrome and you don't know exactly what you're dealing with as well. So we talked about edema as part of the criteria for nephrotic syndrome. But then this question comes to mind that can you really explain the mechanism of edema in the setting of nephrotic syndrome? We all know that definition of edema is the clinically palpable accumulation of sodium and water in the interstitial fluid compartment. But how does this happen to the point that you're able to touch the edema? And when you're trying to do the physical exam on your patient, when you push your finger on their legs, you're able to make a dent. So basically, you are able to touch the extra sodium and water with your finger. Like you're able to see that in the, you're able to feel that in the interstitial fluid compartment. How does edema happen in the nephrotic syndrome? Some facts. If you're able to touch the edema and you're able to touch and feel the sodium and water in the interstitial fluid in this interstitial compartment, then it means that you have the movement of the sodium and water has been going on for a long time, and the amount of fluid that is moving around in your patient's body is really high. You usually don't see the edema if the process just started 2 weeks ago or 3 weeks ago. So this process has been going on for a while. Your patient probably had bubbles in the urine. They didn't feel good. They were having like fatigue. They were tired for a while. And they thought that, oh, okay, maybe it's just because I'm working too much, or I'm not eating well, or I'm trying to lose weight. Maybe that's the reason that I don't feel good. And they didn't come to the doctor. But when you are able to feel the edema, the process has been going on for a while. So this is important because whenever I see a lot of edema on my patients, I usually try to ask questions from the past, like, when was the first time when you felt like something is wrong? When was the first time that you saw bubbles in your urine? And this way, I'm going to get more accurate history from my patients. Because if the process has been going on for years or months, I want to know about that. The longer that they wait to come to the doctor, you're going to see more swelling in your patients, and they're going to give you a detailed history about, well, I've had symptoms for a while. I feel like for the past year, I haven't been myself, or I've been feeling tired. Oh, by the way, I saw bubbles in my urine last year as well. And then this kind of history is going to give you this understanding of probably fibrotic tissue is going to be on the higher side for my patient. This is most often the edema that happens in your legs or on the upper extremity, often is due to an elevation in the capillary hydrostatic pressure. Less frequently, you're going to see the edema because of the increased permeability of the capillary permeability, or reduced plasma oncotic pressure, or lymphatic obstruction. I want to talk about the mechanism of edema a bit, because if you understand how edema happens, then the treatment and deciding about treating your patient is going to be much easier for you. Let's learn about some definitions. So going back to our case, we have a patient who had 5 grams of proteinuria, comes to your clinic, and you do the physical exam, and on her legs, she has 3+ edema. How does that happen? We know that the edema that we see is the accumulation of sodium and water, but how does this shifting happen? So there are these terms that we need to know before being able to understand the mechanism of edema. So you have capillary hydrostatic pressure. This pressure is the pressure that forces fluid out of the capillaries to the interstitial compartment. And the normal range is going to be something between 30 to 45. Then you have interstitial hydrostatic pressure. This force is going to be fighting against the hydrostatic pressure, the capillary hydrostatic pressure. So basically, you have a lot of fluid, you have a lot extra pressure, extra sodium inside your capillaries, and that's going to increase the hydrostatic pressure. But then the interstitial compartment is not going to sit back and say that, oh, that's okay. If you have extra work, if you have extra sodium, just give it to me. I'm going to tolerate the extra pressure. They're going to try to fight back, and they're going to say that we don't want the extra pressure. We don't want the extra sodium. And that's going to be called interstitial hydrostatic pressure. Then you have plasma oncotic pressure, and this pressure is dependent and depends on the amount of albumin and protein that you have inside the capillaries. And then you have interstitial oncotic pressure. So whenever we talk about oncotic pressure, it's related to the amount of protein that you have in that area. Whenever we talk about hydrostatic pressure, we are talking about water and sodium. So what happens in the setting of edema? The interstitial oncotic pressure is derived from the passage of plasma protein across the vascular endothelium. So basically, as we said, whenever we talk about oncotic pressure, it's going to be the amount of protein that is moving around and is going to the interstitium. And then the interstitial hydrostatic pressure only ranges between 0 to 2. So I said that whenever we are talking about hydrostatic pressure, we are talking about sodium and water. But let's remember that the amount of sodium and water that we have inside the capillaries is much higher than the interstitial compartment. So that makes sense that your hydrostatic pressure in the interstitium is going to be much lower than inside the capillaries when you compare them. The interstitial oncotic pressure is derived from the passage of protein, as we said. And that pressure is going to be something around 5 to 10. So not a high pressure anyways. So when we are talking about the interstitial pressure, comparing to the capillary pressure, so in the beginning, even without having any diseases or any extra sodium on water, the pressures inside the capillary is already higher than the interstitium. So if they want to push something, if they want to push their extra work or their extra sodium and salt to the interstitium, they should be able to, because they are more powerful and they have more pressure in there. And then the lymphatic flow is something that might affect the edema in this setting as well, because if you are having issues with the lymphatic flow, then you're not able to, it's going to increase the limit of edema formation. So because you're not able to drain the lymphatic, like you don't have a good drainage for the lymphatic flow as well. So we talked about the pressures. In the setting of edema, because you have a lot of sodium and water inside the capillaries, then your hydrostatic pressure inside the capillaries is going to go up, and you're going to have lower plasma osmotic pressure, the oncotic pressure. Osmotic and oncotic, they are the same. And as we said, the osmotic or oncotic pressure is related to the amount of protein that you have. Why do you have a lower osmotic pressure in the plasma? Because you're losing protein from your urine and your albumin is low. So it makes sense that your oncotic pressure drops. So basically, your hydrostatic pressure is the pressure that wants to get rid of the sodium and water. It's going to push the sodium and water to the interstitium, and that pressure is going to be increased. The oncotic pressure, the pressure that is going to try to keep the water inside the capillaries, is going to be decreased because you don't have the protein anymore. You're losing the protein from your urine, and albumin has dropped. And instead, you have the increased interstitial osmotic pressure because you're pushing the proteins. Not only you're losing the protein from your urine, but because of the issues with the capillary basement membrane, you're losing the protein and you're pushing the protein to the interstitium as well. So you're going to have increased interstitial osmotic pressure as well. And you're going to have increased capillary hydrostatic pressure. This is a picture that I love, and it's going to show you how we fight between pressures in order to form edema. So your capillary hydrostatic pressure, as we said, is going to be increased, trying to push out the sodium and water to the interstitium. And then your interstitium is not going to sit back and say that, okay, I'm going to accept the extra pressure. It's going to fight back with the interstitial fluid hydrostatic pressure. Then your capillary oncotic pressure is going to drop. And the reason that you see this arrow to this side is that it means that when your oncotic pressure is the one who's responsible to try to keep the sodium and water inside the capillaries, because wherever you have protein, the protein needs water and sodium. But then this pressure is going to be decreased because you're losing your protein, and your oncotic pressure is going to be on the lower side. And instead, your interstitium oncotic pressure is going to be increased because your protein is just shifting from inside the capillary to the interstitium. So as a result, you're going to have more pressures, more pressures of hydrostatic pressure inside the capillaries. And as a result, you're going to push a lot of sodium and water to the interstitium. As we said, this is the mechanism of edema formation. And it's really important to understand that. And it's fascinating because a lot of patients that come to my clinic, they just ask me that, hi doc, so just tell me, like, how does this edema happens in my leg? How does I have this much of swelling? And how can I get rid of that? How does it work? So it's really good to have a good understanding of that. So you can tell your patient, this is all sodium and water. And once we treat your kidney disease, once we treat your lupus nephritis, you're not going to lose that much of a protein, and you're going to have more protein inside your capillaries or inside your veins or arteries. This is the way that you can explain it to your patients, and hopefully you're going to be able to hold on your sodium and water, and you're not going to see this much of a shifting. And that's the reason that we have to treat your underlying disease. Another visual abstract to show you the increased pressures, hydrostatic pressure inside the capillaries. So we talked about the altered capillary forces. So we know about the increased hydrostatic pressure and decreased oncotic pressure inside the capillaries. And we're going to have the decreased sodium and water excretion in general when you have edema as well. And we talked about the difference between these pressures as well. So as we said, as your serum albumin drops in the nephrotic syndrome, or as an example, in diabetic nephropathy, your plasma oncotic pressure is going to change, and you're going to have shifting of fluid from intravascular space to the interstitium, and you're going to have edema formation. And this is kind of the main mechanism for edema formation. There is another theory that is called underfill theory. And since the patients in these situations are going to be intravascularly depleted because you're just pushing all the sodium and water to the interstitium, then you're going to feel like hypovolemia. You're going to feel like a patient who's had nausea and vomit for a long time. And that's going to activate your RAS system and sympathetic system. And that's going to cause more sodium and water retention. And over time, because if you don't have the RAS activation, eventually there's not going to be enough sodium and water to shift it to the interstitium. And the reason that edema gets worse over time is that the RAS system gets activated and you just keep retaining more sodium and water because your body feels like you're volume depleted and you shouldn't get rid of the sodium at this point. And that's the reason that if you don't treat these diseases over time, you're going to see more edema and more edema over time. And if your patient comes to your clinic and they already have 3+ edema, that's the reason that it means that this process have started a long time ago, probably a couple of months, and it didn't start yesterday. Even if the patient tells you that I didn't have any swelling and it just started last week, they probably had it, they just didn't notice it, because this process, it takes time. You have to have these changes in the pressures, you have to shift the sodium and water into the interstitium. After you shift that, then you're going to feel intravascularly depleted, and you're going to feel like a hypovolemic patient. Your RAS system is going to get activated. Over time, you're going to retain more sodium and water, and that's going to increase your edema. So it's not something that happens overnight. So as we talked, nephrotic syndrome, as we said, that there is a criteria. And one of the criteria for that is low albumin, because you're losing protein in your urine. And that's going to decrease your intravascular oncotic pressure. This is going to cause the fluid shift into the interstitium. And because of the shifting, you're going to feel like you're volume depleted, and you're going to be intravascularly volume depleted, like you don't have enough fluid volume inside the capillaries anymore. This is going to activate your RAS system, which is the most powerful system in the setting of hypovolemia. This is the system which is saving your life when you have a really bad nausea and vomit, or you've been dealing with diarrhea for a long time and you're really hypovolemic. So if this system gets activated, you're going to retain a lot of sodium and water. And this process is making RAS to wake up and work really hard. And the problem with the nephrotic syndrome, you're not volume depleted in this situation. It's just the shifting of the sodium and water that makes your body think that you are volume depleted, but you actually don't need extra sodium. You already have this extra sodium and you're just shifting it to the interstitium. So by RAS activation, everything is just going to get worse. If you had 1+ edema, from now on, you're going to have 2 or 3+ edema. And if you don't deactivate the RAS system, your edema is just going to get much worse over time. And then you are going to have the sympathetic system as well. You're going to have reduced AMP and you're going to have an AVP release. But these factors, comparing to the RAS system, are not as strong as RAS system. And that's one of the reasons that we want to deactivate RAS system in the setting of nephrotic syndrome as well, because this is one of the ways that you can prevent further edema for your patients. There is another theory. So we talked about underfill theory, and there is another theory that is called overfill theory. In this theory, we believe that shifting of the fluid happens because you just have a lot of sodium and water inside the capillaries, and you have to shift it because you don't have enough protein inside the capillaries to keep the sodium and water inside the capillaries. So if you have, that's the reason that the shifting happens and you have more fluid in the interstitium. So two theories, and people, they just, these are the things that we are not able to prove it by 100%, but both of them, they make sense. And we need to have a good understanding of both. If you ask me, I feel like it's just a combination. You're overfilled with sodium and water, and you have this extra sodium and water that you want to shift it to the interstitium, and you don't have enough protein to keep on them inside the capillaries. At the same time, when after the shifting happens, your RAS system gets activated because your body feels like you're just hypovolemic, and your RAS system wants to save your life, and it gets activated, and that's making your edema getting much worse. So I got this from the NephSim, and this is a really good algorithm. If you see, this is the criteria for nephrotic syndrome. As a nephrologist, it's really important for me to understand that using these labels, and when you're presenting a patient, when you tell me that patient has nephrotic syndrome, it's really important to me that I make sure that my residents and students, they know what they are talking about. So you need to know the criteria. So when you tell me that a patient has nephrotic syndrome, in my mind comes in that, okay, we have a lipid panel on this patient. We know that patient has coagulation issues. We probably have some fatty ovals in the urine as well, and the proteinuria is more than 3.5. About nephrotic syndrome is that with like everything else in medicine, we need algorithms to be able to kind of make a decision about therapy. Otherwise, there's going to be a lot of differentials, a lot of diagnoses flying around, and we have to be really systematic about approaching to our patients. And the reason that these algorithms help us is that we don't want to miss any important diagnosis, any important differentials. So these algorithms help us to just think about all the possibilities for our patients. So whenever you tell me that, okay, this patient has 5 grams of proteinuria, has edema, albumin is low, lipid panel is off, they have coagulation issues, and so I think that patient has nephrotic syndrome. In my mind, after that, I immediately think about, so I have to diagnose this patient. I want to know that if this is a primary or secondary nephrotic syndrome. So what does that mean when we talk about secondary disease? It means that it's secondary to something else. Does the patient has hepatitis? Do they have like a cancer that is causing membranous nephropathy? Do they have, like, for example, if they have membranous nephropathy, is this because of the underlying lupus? If they have FSGS, is that because of diabetes or not? Is that because of hypertension? Are they using any specific medications? Are they drug users and they're using heroin, or have they been on biphosphonate because of their osteoporosis? Or do they have, as we said, any malignancies, have been taking any NSAIDs for chronic pain? So why is it important? It's important because if it's secondary to something else, then I have to remove that cause. If the patient has been taking tons of NSAIDs, ibuprofen, for the past couple of years, and now they have nephrotic range proteinuria, the first thing is that to remove that offending agent. I'm going to tell my patient that you should stop taking NSAIDs, and let's see if your proteinuria improves. If they have a really bad diabetes and their A1C is high and their blood sugar is not well controlled, and they have FSGS secondary to diabetes, then I have to control their blood sugar for them in order to improve their kidney function. Or if they have HIV or they have hepatitis, I have to treat the underlying disease. I have to start treatment for the HIV, or I have to treat the hepatitis in order to help them with their kidney function. Then we have another category that is primary, which is not secondary to anything. It's happening because of an autoimmune disease or another process. It's just genetic, or it's just happening as their immune system regulation is changing. For example, if you have a patient with membranous nephropathy and their antibodies like PLA2R is positive, it usually means that this patient has primary membranous nephropathy. Or if you have IgA nephropathy, if you have minimal change disease, if you have FSGS, that is APOL1 positive, and you do the genetic testing for them, it's probably primary. Why is it important to know that if it's a primary disease, if it's a primary kind of nephrotic syndrome, is that you usually start these infusion things and then the chemotherapy for the primary disease. As I said, if you have some changes to your kidneys because of diabetes, hepatitis C, or Hep B, or HIV, you have to treat the underlying issue. If there is nothing there and it's happening because of the immune system dysregulation, then you're going to treat them, for example, with rituximab, Cytoxan, or other chemotherapy agents. Or sometimes we have newer options for them, and we can treat, for example, IgA nephropathy with some newly diagnosed, newly discovered pills or anything. But again, it's gonna regulate your immune system, or you have to start them on high-dose prednisone steroid to regulate their immune system. I try not to use autoimmune in this setting because not all of them are secondary to autoimmune diseases. And nowadays we are using the term dysregulation in the immune system in the setting of primary nephrotic syndrome. So this is a fun picture. We talked a lot about the nephritic syndrome and nephrotic syndrome today. And as we said, in the setting of nephrotic syndrome, you have a typical patient with a lot of edema. You have massive proteinuria. It shows that the dog is trying to eat this because it's a lot of protein and he's trying to build muscles. You usually see that your patient's telling you that I see bubbles in my urine, and that's protein. So that's one of the main questions that I ask from my patients when they come to the GN clinic. Say that, have you been seeing bubbles in your urine? And when you're flushing, are the bubbles going away, or it's hard to flush them away? Because protein is kind of stinky and it's gonna sit there and it's not gonna be easy to clean out the sink. So they usually have a lot of protein in their urine in the setting of nephrotic syndrome. So they usually tell me that, yes, I've been noticing that I have some bubbles. My urine is kind of foamy for the past couple of months. Or if they haven't been paying attention, they might say that it's just harder to flush my urine, and sometimes I have to flush twice. As we said, because of the proteinuria, your albumin is going to drop, and that's going to make your edema worse. And that's one of the reasons that you see a lot of peripheral edema in the nephrotic syndrome. You have hyperlipidemia in the setting of nephrotic syndrome. And that's one of the reasons that we start medications for their cholesterol, because sometimes it takes a lot of time, or it takes a while to treat the nephrotic syndrome. Imagine that you have a patient with lupus nephritis that now has developed nephrotic syndrome, and you're treating them with pills or even Cytoxan, rituximab, or any choice, like depends on the lupus nephritis class. And then they have high cholesterol as well. It's going to take at least 6 months or more in order to treat their proteinuria. And after that, it's going to take a while for your body to regulate the systems again. So your hyperlipidemia is going to be there at least for a year or two. So that's the reason that we start treatment for their cholesterol with another pill. We start a statin for them, and we continue that. Once their disease is in remission, then we're going to repeat their lipid panel to see that if we see any improvement. And then we're going to give them a trial of a statin. Then we're going to repeat their lipid panel and see if it's going up again. Sometimes it could be secondary to something else. Sometimes they have hyperlipidemia because they have these familial issues, or they have hyperlipidemia by itself, and you have to continue a statin for life. Comparing that to the nephrotic syndrome, we said that usually your urine is gonna come in and say that my urine looks like the Diet Coke. This is one of the things that my patient told me the other day. And so, as we said in the textbook, we're gonna hear about that as well. So it's gonna be cola colored urine because you're just having a lot of blood in your urine. You usually have more hypertension in the setting of nephrotic syndrome. And you're gonna have, like, as we said, it's probably part of the hallmark for IgA nephropathy or vasculitis. These are the diseases that you usually diagnose with hematuria. With that, I'm done. I'm gonna take questions. Thank you for listening to me.
Thank you very much, Dr. Norouzi. That was a really good presentation. I think it's a very challenging topic, and so the way that you presented made it a lot more clear, especially with all the clinical pearls. If anyone has any questions, feel free to Dr. Chinda team any questions and in the chat as well. Looks like there's a question in the chat. Why is there lipidemia?
Yeah, that's a really good question. And it's probably because when you're losing protein, you're going to cause dysregulation in the lipid, because you have to be able to regulate the synthesis and also regulate how much cholesterol like you are making, and also how to get rid of that, right? So it's going to cause dysregulation in these mechanisms as well. If you ask me about the exact mechanisms, it's not clear. And the same as coagulation system, you might ask me like, why do we have more DVTs in these patients? And we exactly don't know. We know that when albumin drops, you're going to have issues in the coagulation system, and it's going to affect your coagulation cascade. But if you want to know it for sure, like 100% and details, it's not exactly clear. Telling sure the principles of treatment. Yeah, sure. I love to talk about that. This is something that I do every day. So thank you for asking that question. So we talked about the proteinuria and in the setting of nephrotic syndrome. So one of the main things that we want to focus on is to see that how we can drop this proteinuria, because as we talked, as long as you are losing protein, you're going to have this shifting of fluid to the interstitium compartment, and that's going to cause worsening of edema, and that's going to increase the blood pressure as well, and it's going to increase pressure inside the glands. So you have, depending, and let me go back to this, depending on what kind of disease you're dealing with, if it's primary or secondary, then you're going to focus on the treatment of the patient. So for example, if you're dealing with lupus nephritis, then, and that's causing nephrotic syndrome for you, you're going to focus on the treatment of lupus. And there are different options for lupus nephritis based on the class. If you are dealing with minimal change disease, we usually do a steroid for these patients. And the amount of prednisone that you use for these patients is 0.8 milligram per kg. For example, if your patient is 60 kg and you want to start the treatment, you start with 48 to 50 50 grams of protein, a steroid, in order to decrease the proteinuria. So that's the induction phase. And then you continue that for at least 3 months. And then you're going to start tapering down the steroid after that. For the membranous nephropathy, you can do PO steroid if it's primary membranous nephropathy, or you can induct them with IV methylprednisolone as well for 3 days, and after that switch to PO steroid. The thing is that a lot of membranous nephropathy in the primary side, they might not respond to only prednisone, so you do something else for that, and you consider rituximab as well. For FSGS, again, you usually start with a steroid to see that if they respond to prednisone. If they don't respond to prednisone, then you're going to call them prednisone or steroid-resistant FSGS, and you're going to move on to other agents such as tacrolimus. Sometimes some studies have been suggesting maybe FSGS can respond to rituximab as well. You have another option of mycophenolate as well. That's a pill that it's gonna come in. You're gonna do it for twice a day, and that's another option for the treatment. For IgA nephropathy, again, you're going to have this option of starting prednisone if the proteinuria is more than 1 gram, or if you can consider a new medication that is called budesonide. It's a delayed release steroid capsule that is just got FDA approved in the United States. It's a new medication to us as well. And if your proteinuria is less than 1 gram and you are in the nephrotic range proteinuria, then you're gonna start supportive therapy. You're gonna try to inhibit RAS system. You're gonna start ACE inhibitor or ARB, and then you're gonna start. Recently here we do SGLT2 inhibitors for the IgA nephropathy as well. You try to control their blood pressure. You're gonna tell them that you have to make sure that your diet, you're not eating a lot of salt, because as we talked about the mechanism of edema, if you're eating a lot of salt, you're actually feeding your capillaries with more salt and water, and that's going to cause more retention, and edema is going to get worse. Yeah, so that's the reason that this algorithm is really important. I feel like the main reason, the main kind of step, the most important step in order to approach to treatment of nephrotic syndrome is to be able to categorize them into the primary and secondary causes. Again, for secondary causes, treat the underlying cause. Sometimes your patient is just really obese and they have FSGS secondary to obesity, and you have to tell them that you have to lose weight really aggressively. And sometimes they might need surgeries as well for the weight loss, and they're not able to lose weight by themselves. These patients might qualify for weight loss, for weight reduction surgeries as well. And then if they have diabetes, as I said, you just tell them, and you have to discuss with them in detail and tell them why is it important at this point to control your diabetes as tight as possible. And you're going to tell them that you are developing something that is called FSGS. It's causing a lot of fibrotic tissue in your kidneys. And if you don't control your blood sugar as soon as possible, it's going to cause more damage. And over time, you're going to need dialysis. So that's the reason that you have to control your blood sugar as much as possible. Our goal here, like based on the guidelines, we're going to keep it, we'd like to keep the A1C less than 7. And I know that diabetic patients it's challenging to have diabetes and be like trying to control your blood sugar all the time. But it's all about education, and it's about teamwork, that you ask your dietitian to talk to them, you work with your endocrinologists, you work with your primary care physicians, and you all try to help the patient to control their blood sugar or lose weight. High blood pressure, the same thing. They have to take their medications. You have to ask them to check their blood pressure every day at the same time, log the numbers, try to adjust their medications whenever it's needed to keep their blood pressure at least less than 140 over 80 for these patients. And then we talked about different viruses that you have to start treatment, especially if it's affecting their kidney function. It shows that it's time, like they're not able to wait anymore, and you have to start the treatment for hepatitis C, hepatitis B, HIV, anything that is causing kidney disease at this point as soon as possible. One thing about nephrotic syndrome is that once you diagnose a patient with nephrotic syndrome, you don't have that much time. If you don't start treatment right away, you're going to have more fibrotic tissue over time. And at some point, if you wait, for example, for 6 months and do the biopsy later on, you're going to see a lot of changes, because once the process starts and the RAS system is activated, then this process is actively attacking your kidneys, and you are making fibrotic tissue every day. So if you have a patient with a lot of proteinuria, or if you have diagnosed a patient with nephrotic syndrome, you have to start the treatment right away. You don't have time to, like, you shouldn't waste any time. If you want to get the kidney biopsy, do it right away. If you know about your diagnosis and you're able to check antibodies for these patients, and you know, for example, your patient has membranous nephropathy, don't waste any time. Start the treatment, start that rituximab, cytoxan, anything that your patient needs. Otherwise, if you wait for like 6 months, a year or something, it might be too late to start these treatments for your patients, and your patients might end up in dialysis anyways. So timing is really important for nephrotic syndrome. And that's one of the reasons that I really want to see these patients at the GN clinic as soon as they have this much of proteinuria. And a lot of times these patients are really young, especially for some specific diagnoses of, like, for example, minimal change disease or IgA nephropathy. These patients, sometimes they are there in their 20s, their 30s. And if you don't treat their kidneys, they're going to go on dialysis in such a young age, and it's going to change their life. They're not going to be to work as much as before. They're going to have fatigue. They're going to feel, their body is going to feel like a 60-year-old. And that's going to be really tough for them.
All right. Good day. I'm Frank Point from Cameroon. So I have a little concern with respect to the definition for nephrotic syndrome. It's true the emphasis here is on the proteinuria, which is quantitative, that above 3 to 3.5 in 24 hours. However, in a setting like ours, where it's really challenging to get that quantification, and all we have to really rely on is the semi-quantitative analysis on urinalysis. So I don't know how that can correlate with the daily quantification, if we can actually use that in combination with the other elements of the syndrome to define the patient as having a nephrotic syndrome.
Oh, that's a really good question. So if you're not able to quantify protein in the urine, then your UA is going to tell you that if you have a lot of proteinuria or not. Because and I don't know how you see the UA results, but in our UA it shows, like, for example, 1+, 2+, 3+ proteinuria. So usually 1+ is not nephrotic range proteinuria. 3+ and more than that for sure is probably towards the nephrotic range proteinuria. So it can give you a ballpark about that. You don't have to collect 24-hour urine in order to see that if the patient has 3.5 grams of proteinuria. It's really hard to collect the urine for 24 hours. Even here, we usually just rely on the spot urine protein to creatinine ratio, and that's how we quantify the urine. I don't know if you have access to the spot urine to protein to creatinine ratio. If you do, you don't have to collect the urine for 24 hours all the time. Based on the guidelines, I know that the gold standard is to collect the urine for 24 hours because that's going to be more accurate. But in real practice, asking someone to just collect the urine for 24 hours all the time, like, because if you have nephrotic syndrome, they go and see different doctors, and different doctors, if everyone wants to collect their urine for 24 hours, it's going to be a lot of work for the patient. And sometimes even that's not accurate, because patient might go to work and they forgot, like, to collect one time, or like they might wake up and forget to, like, discard the first urine. Like, it's a lot of instruction for collecting urine, and after they collect the urine, they have to go back to the lab and give it to the lab at the same day. So sometimes they just forget and they go to the lab the next day or something. So it's not always that accurate in real life as well. So we depend on the urine protein to creatinine ratio, like a spot ratio as well. And I think that's accurate most of the time.
Thank you.
Sure, of course. Good question.
Hello.
Hi.
Sayna Norouzi, thank you so much for what was an excellent talk and so much relevant in our context. So, and we are so happy about the way you kept it simple. So thanks a lot. So Dr. Frank Foy already mentioned some of the difficulties we have here. Actually, we do not have access to spot protein creatinine ratios. We did have that in the past, but not right now. So often we have to rely on this dipstick showing us 3+ and say, okay, this is probably tending towards the nephrotic range. And we associate that with other clinical symptoms to diagnose nephrotic syndrome. So that's what we are really restricted to right now. When you do some reading about this, you hear about PCR, protein creatinine ratio, you hear about ACR, and some controversies about which one is preferred to determine, nephrotic range proteinuria. Now, what are your thoughts about that? Should there be a preference between those two?
If I get it correctly, so you have access to the UA and it's going to show you that the 2+ and 3+ proteinuria, right? And you don't have the spot urine protein to creatinine ratio, is that right?
Exactly, as we do not have ACR or PCR.
I mean, the thing is that you work with what you have, right? So if your patient have other symptoms, like if you see a lot of edema in your patients, like for example, on your physical exam, when you're trying to make a dent, you see that, okay, this patient has probably 3+ edema and it's been getting worse over time. And they say that their urine is really foamy. And when they're trying to flush to flush after they urinate, that it just doesn't go away. It's just so stinky, it's different. Then it shows that probably they have a lot of proteinuria. I mean, it's not about numbers, honestly. I think like in medicine, we just treat human, right? We don't treat numbers. And if they have these symptoms and they're gonna like their history is kind of telling you that they have a lot of protein, I would trust that. And even if you don't have the number, and especially if your UA shows that 3+ or 2+ proteinuria, then I would trust that and say that probably it's more than 3 grams or 3.5 grams. And I would start treatment and I would start like categorizing them in my mind, like approaching to nephrotic range proteinuria. As I said, these are just numbers to guide us, it's not like I don't want to, I usually, sometimes even like my patients, they might not have 3.5 grams of proteinuria and they might have 2.5. Is it going to change? Like, for example, I'm going to think about membranous nephropathy, honestly, anyways, as well. Maybe I'm just catching my patient much earlier. And if I've seen the patient, like, if I had seen the patient in a month or so, they might have like more than 3 grams of proteinuria. So it's not about the number all the time. And I feel like all these guidelines and all these numbers are kind of helping us to guide and to think and categorize these patients into different like boxes and everything to come up with the differentials. Otherwise, when you see proteinuria, which is unexplained in your patients and they are in the younger ages and everything, honestly, you have to think about the nephrotic range proteinuria differentials anyways. So I don't want you to feel like, okay, I don't have access to this number. It's going to be more complicated to manage these patients, because no, like even here that we have access to all these numbers, even if they don't fill out the exact criteria based on the textbook, we still think about all of these diagnoses, especially if it's unexplained, they don't have diabetes or high blood pressure or like, any other things to explain the proteinuria, we still think about membranous nephropathy or minimal change disease. As I said, like there was like an algorithm here from Curbsiders here that it shows that there is a range, right? Like even membranous nephropathy can cause nephritic syndrome as well. Like lupus nephritis can come in different shapes and kinds of like presentations, even IgA as well. So a lot of these things are always on my differentials, even though that the proteinuria or they don't fill out the criteria for nephrotic syndrome. Who wants to miss something as important of like membranous nephropathy or lupus nephritis in their patients? So you have to think about all of them. And yeah, a lot of times I feel like if you look at your patient and you listen to their history, it kind of like they're telling you what they have. They're going to tell you that I have a lot of foamy urine. In the beginning, I've noticed some swelling in my legs. It's been getting worse for the past month to the point that I feel like it's not easy for me to walk around. I feel like sometimes I have headache. They are developing like a new onset high blood pressure. These are the things that, you make you think that probably they're developing nephrotic syndrome, and maybe just early stages of nephrotic syndrome, and they might have like a full-blown like nephrotic syndrome in a couple of months, or they already have it. So yeah, numbers are just numbers to help us.
Thank you. Now, can you please just make a quick comment on anticoagulation, on prophylactic anticoagulation in these patients with nephrotic syndrome? Now, is that something you use routinely, and when do you use it?
Well, that's a really good question. And there is a lot of controversies about this. And we talk about this on GlomCon all the time. There is, if you want to talk about the guidelines, so if your albumin is less than 3 grams or 2.5 grams, then you're going to consider starting anticoagulation. And anticoagulation that is proven from the literature is the warfarin. So you can start warfarin and you're going to plan to keep their INR between 2 to 3. And then you start treatment for the underlying disease. For example, you start treatment for lupus nephritis or membranous nephropathy, FSGS, and then you check your urine protein to creatinine ratio or your albumin as a marker after a couple of months to see if the patient is improving. If albumin is now more than 3 and they are improving, their edema is improving as well, they tell you that I don't have as much as foamy urine anymore, then you can stop warfarin at that time, okay? But if you feel like the patient is going to take a while to improve, for example, you check the albumin for after 3 or 4 months and you see that still 2.1, you still like you have albumin of 1.9, you continue that. Like you don't have to be in a rush to stop warfarin for these patients because these patients are at high risk for developing DVTs. And if you don't do warfarin, then they're going to develop DVT and it's going to make it more complicated for them. At the same time, warfarin is not completely safe. They're going to be at risk of increased bleeding. Sometimes patients have history of brain bleeds in the past, so they're not a good candidate for warfarin as well. So you have to discuss this with your patients. If you're not starting warfarin, they need to know that they are at risk of DVTs. They have to walk around all the time, make sure that they are exercising. And as soon as they feel like they have pain, in one of their legs more than the other one, if they have swelling in one area like more than the other area, like for example in their left leg comparing to the right leg, in their right arm comparing to the left arm, like there is a difference in the edema, or they have shortness of breath because they can develop PE as well, they have to come to the emergency room right away. So they just need to know that they have issues with the coagulation system and they might develop a DVT anytime. Here, sometimes it's not based on the guidelines, but we use newer agents instead of warfarin because for warfarin, the patient has to check the INR all the time. But it's not proven from the literature. It's just something based on the expert opinion to start something as a prophylactic, like for NOACs, like a newer agents for DVT prophylaxis. But based on the literature, warfarin is the main medication that you start. You usually start it once your albumin drops to less than 3, and you continue that until you see an improvement in your patients, either in edema, foamy urine, or the amount of albumin. You want to see a trend. If your albumin is going up, for example, you check it and the albumin is 2.7, next time is 3, you don't have to stop warfarin at that time, but you have in your mind that this patient is improving. You again check the albumin in 3 to 4 months and you see that this time albumin is 3.5. So you know that patient is in the right direction and they're just responding to the therapy, and that's a good time to stop warfarin. I'm not a fan of continuing warfarin for a long time. I usually tell my patients, this is hopefully short term, and as soon as you respond to the therapy, we're going to stop this medication as well.
Okay, thank you once again. Great talk.
Sure, of course, really good questions.
Pranati, I think we are through from this side.
Okay, perfect. Yeah, those actually, I was also going to ask about the hypercoagulable state. So that was a really good question and makes sense. Good. So that was really good. Thank you, Dr. Norouzi, for telling us all about proteinuria and nephrotic syndrome. I think this is a very interesting one because yes, there's guidelines and all these numbers we can use, but you're right. There's so many clinical signs that can point you in the direction of nephrotic syndrome, whichever one. So this is a very good topic to go over clinically like this. So we really appreciated you coming, and thank you everyone for joining as well and bringing your questions. Your questions are what help us make these presentations better. So we'll catch you in the next one. Nice seeing everyone. Thank you.
Thank you very much.